Good afternoon. Welcome everyone to today's endocrinology grand rounds. Today for us, it's a very special day to get someone back here who was at the center of this for 20 plus years. Um, Dr. Steve Winters, who is currently emeritus professor in the Division of Endocrinology and Metabolism at our university. Dr. Winters went to medical school in Syracuse and did his residency at Strong Memorial in Rochester, and subsequently did fellowship at the NIH, and spent about 20 years at the University of Pittsburgh, rising to the level of professor and tenure professor before he moved to Louisville in 1999, and spent 21 years here. We had the good fortune of having him as our chief and colleague, mentor for many of our junior faculty, not only in our division, but also in other divisions and departments at the university. He he has been world renowned for his work. He's the excellent clinician, a great educator, and both a basic and clinical researcher. So his work over the years has been funded by the National Institute of Health and other organizations. And he has focused his work on the pituitary and male hypogonadal pituitary, hypothalamic pituitary gonadal axis, and has over 200 publications. The biggest thing for us being with him over the years is that he has a rigorous scientific approach, and whenever he talks to, whether it's be a fellow or a colleague, he brings out the best possible approaches to address a problem, and we have all benefited from that. He retired in 2020, but has kept up scientific interest and activity. I think his most recent publication was this year. So, and if there is anybody who can talk on this topic in the world, it is Dr. Winters on the sex hormone-binding globulin. There is no doubt that he is kind of the world authority on this particular topic. And I think that was the review that he wrote this year, which was published. So we are very pleased to have him here to talk to us about sex hormone-binding globulin, biology and biomarker. Dr. Winters.
Thanks so very much for the kind words. And of course, it's quite nostalgic to come back after spending 20 plus years here, you can imagine. Any event, sex hormone binding globulin has been an interest of mine for a very long time. I was a fellow at the NIH and did some work using a radioreceptor binding assay with concanavalin cephorose in 1977 or so. And I continued my interest in SHBG through that. So no disclosures. And so sex hormone binding globulin is a homodimeric glycoprotein. So two different dimers right here, and the carbohydrate down over here. And it weighs about 100,000 molecular weight. And differences in the glyco proportion here among individuals and between illnesses and healthy people are established, but don't have a real understanding of what they really mean. The levels of calcium and zinc influence the affinity of the SHBG for steroid hormones, which is greatest for dihydrotestosterone, more so than testosterone, and about 10% as well for estradiol, so that changes in SHBG influence androgens much more than they do estradiol. So it's produced by hepatocytes. It binds steroids selectively with high affinity, and in doing so slows their metabolic clearance. It's expressed by the fetal liver in most species and in humans throughout the life cycle, and it regulates the proportion of bound and free steroids and thereby entrance into cells. It's encoded on this chromosome 17 with 8 exons, and there's an alternate promoter in the testis, which results in a protein called androgen-binding protein, which plays a role in maintaining high testosterone levels in the testes, which are important for spermatogenesis. So this was done by Dr. Darshifkar. Maybe she's dialing in, I don't know. In any event, the SHBG is found in the fetus. What exactly it does in the fetus isn't clear. And it's found in the cord blood of newborns. And here you can see it on the heel stick a couple of days later. The levels in males are a little bit higher than in females, but in our study wasn't statistically significant. And there was a slight difference between cord blood and heel stick, but of course these are very different kinds of samples, and whether it has to do with biology or sample preparation, we don't really know. So right after that, the level of SHBG rises a large amount, and it maintains a very high level like that until about ages 8 to 10. And here we see males and females, women and men, and you can see that there's a drop which occurs right before age 8 or 10, and that levels in males remain lower than in females. And this rise in females is probably because estradiol increases SHBG production. And as we get older, then the level rises, and it's more dramatic in males than in females. So the increase in newborns is generally thought to be due to changes in thyroid hormones that occur at birth. So these are from papers a very long time ago, our free T4 and T3 levels in the first 72 hours after the babies are born. And you can see that there's a dramatic increase in thyroid hormone levels. And it turns out that thyroxine increases SHBG expression, and we'll talk about it a little more. And then here you can see in a cell line, the production of SHBG is higher when the cells are treated with thyroxine. And you can see that there's some increase in the mRNA for SHBG compared to controls when the cells are treated with thyroxine. So this superimposes the change in SHBG that I mentioned a moment ago on top of other events throughout the reproductive hormone cycle. I only put males in here because it gets too complicated. But you can see then that, of course, during the fetal life, there's a rise in SHBG. But I want you to look at this. This is called mini puberty. So mini puberty is the increase in LH and FSH and in sex steroids, which occurs right after birth and lasts maybe 3 or 4 months, and then goes away, and the levels remain quite low until puberty occurs. So during this mini puberty, this increase in FSH is thought to be very important in stimulating the cell division of Sertoli cells. So it causes the Sertoli cell mass to increase, and every Sertoli cell can support a certain number of germ cells in adulthood. So having more Sertoli cells based on the mini puberty causes a higher sperm count. So there's quite an important effect of mini puberty on the testis. But of course, this increase in testosterone would be expected to masculinize a newborn fetus. And that's necessarily not what you want. So what happens is that this SHBG here binds up the testosterone so that much more of the testosterone at that time during mini puberty is bound than free. And the way these workers dealt with this is measuring salivary testosterone. So there are hormones in saliva, but they're only free hormones. Bound hormones don't wind up in the saliva, only free hormones. So you can see that the testosterone level in the infants is quite substantial and not that far different in the adolescents, but the salivary is a surrogate for free testosterone is much, much lower, and the percent there salivary is much, much lower. So the textbook information is that the rise in SHBG during childhood protects males from being masculinized at a time when you don't want them to be masculinized. And here you can see the decline. Very often you'll read in books that the decline in SHBG is due to sex hormones because it occurs not so far before puberty. But that's not correct. You can see right here that the decline is really very clearly occurring way before puberty. You can see all of these individuals are individual boys and individual girls. And there's really no way that this is a curve that's stable through age 10 and then declines. And why exactly the decline occurs is not so clear, but I think it's metabolic. And the reason for that is that this is a line of SHBG levels in boys with hypopituitarism, either partial or complete. And sadly, they didn't put in the dots, so you only have this crummy line to look at. But the levels go down. And this then can't be due to pituitary hormones because this decline is occurring in people with hypopituitarism. And I think this is on a metabolic basis. And much of the talk today will be on how the metabolic basis and the metabolic syndrome relate to SHBG. So this is concentration profiles in women, adult women, and you can see they're relatively constant throughout the 24 hours. And the protein has a very long half-life of several days. So it's unlikely to change like cortisol does throughout the day and night. And this slide also shows that women with PCOS in the open circles have much lower levels than the normal controls in the upper circles. This slide comes from a study just examined men and women in the NHANES program, and it just gives what you might call a normal range, 12 to 92 and 18 to 211. And you can see that the distribution is somewhat skewed with higher levels occurring in both men and women. So here we see the levels of SHBG during the menstrual cycle. They are highest in the luteal phase, then in the follicular and ovulatory phase. And this is probably due to the production of estradiol during the ovulatory cycle and in the luteal phase. So estradiol levels over this time would be higher than here. And with the long half-life, it expresses itself in the luteal phase. This study also compared women from Sweden, where the paper was done in black, with West Asian women living in Sweden, most of whom were Iranians. And here you can see that the levels in the Iranian women are much, much lower than the levels in the Swedish women. And clearly some of the effect to maintain SHBG is genetic, because this is a study of twins. And the way they do these twin studies is you compare twin A and twin B. And if the concordance is perfect, whatever twin A has, twin B had, like type 1 diabetes in identical twins, right? So here you can see the concordance is not perfect. It's only 0.52. In other words, the levels were similar between twin A and B, but not exactly the same. But the concordance is much higher than in the sibling pairs and in the father-son pairs. So this means that there is a genetic component to maintaining the level of SHBG in blood. During pregnancy, there's a dramatic increase in testosterone. I don't know if you ever measured testosterone in pregnant women, but if you do, you'll be shocked. Here you can see these are normal male ranges, 500 nanograms per deciliter. Here they are. But what happens is that the SHBG rises and rises and rises, so that most of that circulating testosterone is bound to SHBG. And the increase in free testosterone, if you will, is present. So don't get burned on that, but nowhere near as dramatic as this. And the rise during pregnancy has a physiological significance. So this is a woman reported in the JCI 20 years ago who has a mutation in the SHBG gene causing a very, very low level of SHBG. And the mutation is a point mutation here and a deletion here in these two exons in the SHBG gene. But here's her story. A 27-year-old woman with a history of regular cycles but mild hirsutism increased dramatically during pregnancy, was associated with deepening of her voice and enlargement of her clitoris. That's masculinization. The pregnancy, though, was otherwise uneventful, and she delivered twin girls with no signs of virilization. And 2 years later, she was quite hirsute and was referred these guys for an evaluation, who found that the SHBG was very, very low and came up with a genetic explanation with mutations here in exons 4 and exons E. And thus, the biological effect of SHBG is to protect women against the hyperandrogenism, which occurs when the placenta makes lots of steroid hormones during pregnancy. There are naturally occurring mutants in the SHBG gene. So in this study, you have the immunoreactive SHBG here, and here you have an SHBG binding, a binding assay. And for most of the patients, they're perfectly normal individuals. They're on this line of identity, and these are sort of wild type people. But here you can see that there are a few individuals in whom there's a higher binding capacity, a bioactivity than expected by the immunoreactivity.
Yeah.
And there are also individuals who have lower bioactivity than expected based on the immunoactivity.
DHE committee went 3.5 hours. This is the summary.
So that
In terms of Ahmed, we give him time till end of the day. If he doesn't respond, we have to
Yeah, yeah, then I'm going to write.
is there a speaker maybe?
That's a
Yeah. Yeah.
Hello, we're hearing you in room 28. Thank you. In any event, so here are another paper, a quite recent paper, showing several polymorphisms and showing that there are individuals who have an higher SHBG level than in the peripheral blood than individuals with a wild type. So this is out there. And it's one of the reasons why some people disparage calculating free testosterone from the SHBG and testosterone levels. There's a little formula to do that. And it's based on having the affinity of the SHBG for testosterone. But if the affinity isn't always the same, they argue that the equation really applies to most people, but not to all people. And therefore, they propose direct HPLC analysis to measure free testosterone. And that's sort of becoming the standard of fare because this objection has sort of permeated into the literature. So if you look at the level of testosterone and the level of SHBG in healthy young people, there's a strong positive correlation. The correlation in prepubertal boys is positive, but much weaker. In men who are being treated with a testosterone gel, it's positive, but much weaker. And in women, if anything, it's a little bit negative. And a fellow named Durand, who's an endocrinologist, I think, in Switzerland, pointed out that during mini-puberty, this strong positive correlation seen in healthy young men holds. So what's the difference between healthy young men and mini-puberty versus prepubertal boys, adult women, and men with testosterone gel, is that during here, the testosterone is LH driven. And in all of these circumstances, the testosterone is pretty much LH independent. So why is that important? That's important because of this beautiful feedback map with kisspeptin, what we talked about with the fellows. And what happens then, of course, this is the positive regulation of kisspeptin causing GnRH, upregulating the subunit genes, stimulating the Leydig cells and Sertoli cells. And then you have negative feedback. So if the SHBG begins to rise like that, the percentage which is bound to SHBG starts to fall, and that causes the level of GnRH in the brain to rise, the level of gonadotropins to rise, and the level of testosterone and estradiol to rise. And all of this then supports what's called a free hormone hypothesis. So the free hormone hypothesis states that only free hormones enter into cells and that the SHBG and albumin bound are a circulating pool, which you measure, but don't have a biological activity. And that's still a hypothesis. Most people believe that, but there are still a lot of controversy and discussion.
Actually, if you go back to the dots, it's an awful lot of scatter.
A lot of scatter.
So,
Well, I mean, there are a lot of I will show you that there are a lot of determinants of SHBG, and there are a lot of determinants of testosterone, so that the scatter is true, but it doesn't bother me. So there are numerous biological, nutritional, and pathological factors which regulate the SHBG. Obviously, we can't talk about all of this in one day, but if you have a patient with a high SHBG, like we just did a little bit ago, you want to look at all of these things here and see if any of them can help explain why the SHBG is high. Now, one of the common ones is hyperthyroidism. And I saw at least a half a dozen patients who were sent to me because they had a high testosterone level. And the doctors then measured the LH and FSH, and they were high. And they wound up with MRIs looking for pituitary tumors. And if they were careful in doing a thorough physical and a history, they would have realized that the men were in some stage of hyperthyroidism. So here you can see how high the SHBG level can be in a hyperthyroid individual and how the testosterone and LH and FSH rise in comparison to normal men. So this is a very clinically important one, terrific exam question. This is another good exam question. What happens in patients with what's called inappropriate TSH secretion? So in patients with hyperthyroidism, the TSH level should be very low. But there are certain circumstances where it isn't, and that's called inappropriate TSH secretion. And among the causes are the heterophile anti-mouse antibodies, which I think you gave a talk about, Stan, many years ago, right? But I think so. And other ones are having a very large TSH molecule, which a low clearance rate, so it accumulates. And of course, taking lots of biotin gums up some of the immunoassays, so you don't want that. But the one that counts here is, do people have a TSH producing pituitary tumor, or do they have an inactivating mutation of the TSH, of the thyroid hormone receptor, to cause TSH and free T4 to be high? So SHBG helps, because if the receptor is mutated, the SHBG level is normal. If the patient has a pituitary tumor, usually the TSH level goes up. And the tumors are also characterized by making alpha subunit, free alpha subunit. And that's not true in the mutants. So some years ago now, maybe about 50, an old friend of mine, Alan Glass, who was a fellow with Ron Swerdloff at Harvey at Harbor UCLA in the 70s, collected blood samples from normal weight and obese men. And he measured testosterone, which was known to be low in obese men, but he also measured SHBG, and he found it to be low in SHBG in obese men. And therefore, the free testosterone levels in the two groups are much more similar. So Dr. Glass found that obesity was a cause of low SHBG, a really important finding. This is from the Puget Sound VA and Dr. Matsumoto and his group. And here you can see display what I was talking about, Stan. So while obesity clearly lowers the SHBG level, there are plenty of men with normal BMIs or even low BMIs who have a low level of SHBG. And for a given BMI, the level of SHBG can vary tenfold. So it's a highly variable situation. This was done by Dr. Aiden. She was a visiting fellow with us, a pediatric endocrinologist who visited with us a few years ago and collect blood at the ULH here. We measured SHBG and calculated how heavy the babies were by doing something called the ponderal index, which is something that the pediatricians use to categorize obesity in newborns. And here you can see this, and it's already present at age 2. The biggest babies have the lowest levels of SHBG. And here she also compared the babies born to non-diabetic women in the solid dark circles with the red circles, which were a combination of type 2 diabetes and gestational diabetes. And it's very clear that the latter group has lower SHBG levels than the former group. But again, notice that the SHBG level can be low in thin babies as well as obese babies. During early puberty, you find the same thing. Girls who are obese, this is a 98th percentile for weight. They have a much lower SHBG than the normal weight girls. Same is true for boys. They have a lower SHBG level than do normal weight boys. In 1993, Berkelin was the first group to show that insulin resistance results in regulates SHBG. So this is the hyperinsulinemic euglycemic glucose camp, which I gather you would learn from the diabetologist about how to do that. I will not embarrass myself by screwing it up. But you can see that the most sensitive patients to the insulin have the highest levels of SHBG, and the least sensitive have the lowest levels. So somehow insulin resistance and insulin sensitivity is one of the players in the SHBG level. Here we have women with PCOS, a common group of patients that we deal with all the time, who were divided into those who are obese, overweight, and normal weight. And you can see that obese, normal weight, and overweight using HOMA, IR is the tracker for insulin sensitivity. The insulin sensitivity goes down. The HOMA goes down. And when the HOMA goes down, the SHBG levels go up. So once again, the correlation between insulin sensitivity and SHBG, which you can do in a much larger group than with euglycemic clamps. Across the metabolic syndrome, regardless if it's adolescent boys or obese Russian men or older men in Baltimore and Massachusetts, the ones with the with the metabolic syndrome always have lower SHBG levels. And the same is true for women. Postmenopausal women with breast cancer, post-perimenopausal women and SWAN, PCOS women. If you have the metabolic syndrome, you have a lower SHBG level than those who don't. So the presence of the metabolic syndrome in adolescence is not common, but this study then examined a large number of girls and boys and found a few with the metabolic syndrome. And in the intermediate group here was those who had one or more features of the metabolic syndrome, but didn't qualify based on all the criteria. And you can see that that group had lower SHBG levels for both girls and boys. And the group who really did have the metabolic syndrome, although we're small, they had the lowest SHBG. So this connection between the presence of the metabolic syndrome and low SHBG is already seen in adolescence. So one of the aspects you know now about the metabolic syndrome is the association with what is now called metabolic associated steatotic liver disease. You know, it used to be non-alcoholic fatty liver disease. It has a new name. And here you can see then that the ones who, among these adolescent girls, the ones who have MASLD have a lower SHBG level than the ones without MASLD. And they also have a much higher HOMA-IR, indicating they're insulin resistant. And they have a bigger BMI. They're more overweight. This study just shows the characteristics of women at menopause. And here they divided the women into quartiles based on the SHBG level. And here you can see the amount of visceral adipose tissue and subcutaneous adipose tissue in relationship to the SHBG, with SHBG rising. As the SHBG is rising, the amount of both visceral adipose tissue and subcutaneous adipose tissue is falling, and the liver attenuation, so a higher level is less fat. You can see that that is all rising. So women with type 2 diabetes, you know, they're going to be overweight, they're going to have insulin resistance, and they are going to have lower SHBG. And the men, likewise, with type 2 diabetes are going to have lower SHBG. This is not true for people with type 1 diabetes. If you look at patients with type 1 diabetes, and I wanted to put the slide in, but I didn't, they don't have it. And I'll come back to that. So here we have individuals with no MASLD, mild MASLD, or moderate MASLD. And here are the men and women. And here you can see that if you have moderate fatty liver disease, you have a lower SHBG in both men and women. And you have higher insulin levels. You're more insulin resistant based on the HOMA. And you, okay. This is Dr. Krishnaswamy's study of children age 5 to 9 whose parents had the metabolic syndrome, either one parent, two parents, or no parents. And she measured SHBG levels in the children. And the boys are in open circles and the girls are in the squares. And we chose younger children, so we preceded then the changes due to puberty. And you can see how dramatic this is, where if your parents have two parents have the metabolic syndrome, that the levels of SHBG are much lower. So something about the metabolic syndrome is already transmitted to these children at age 5 to 9. What exactly it is, we never figured it out. And sadly, it was such a small study that all the major journals turned us down. And she ultimately published it in Endocrine Practice. So not only are there low levels in diabetes in the metabolic syndrome, but low levels of SHBG predict the development of those disorders. So this is work from, I think, Norway. And this is the SHBG concentration. And this is how many patients develop diabetes when followed for 12 years out of 1,462. Quite a nice group. So you can see how dramatic it is. So if you have a low level of SHBG, you have a 20% chance of getting diabetes over the next 12 years, at least according to this study. Here is another one. These are in men, the Massachusetts Male Aging Study. 5% of the men developed diabetes after a 7 to 10 year follow-up, and blood samples were drawn, in the 1980s. The ones who developed diabetes have a lower level of SHBG than the ones who didn't. So it's a marker for the future development. Is there an overlap? Yeah, but nevertheless, there's quite a statistical significance. And this one looked at the same Massachusetts male aging study somewhat later. And here are the SHBG quartiles, with this being the lowest SHBG level here. And their risk of developing diabetes is 1.57 versus the reference group who had SHBG level above 40. So one of the things that might be useful in prediction is, do women develop type 2 diabetes, gestational diabetes during pregnancy? And how do you predict that? So this study looked at those who did develop gestational diabetes and those who did not. And those who did had a bigger waist circumference and had lower levels of SHBG than the women who did not develop gestational diabetes, even though there was a big overlap and the BMI was really not statistically significant between the groups. So obesity alone was an insufficient predictor. And if you use this cut point of 62.6 nanomoles per liter, 92% of the women who developed diabetes had a value below that. It would be useful then if you could also track the SHBG during the pregnancy, but the pregnancy, remember, results in very high levels of SHBG from the estrogens coming from the placenta, and that increase during gestation here sort of overwhelms the difference between the gestational diabetes and normal control group, so that there is a slightly higher level in those without gestational diabetes, but there isn't any significant difference between the two groups. So the use here has to be before the pregnancy. There's an increased risk in heart disease. This is a study from the what's called the UK Biobank, which is a large study conducted in the UK, which combined a whole bunch of descriptors, including genetic studies of the patients, a very large number of patients, 128,000 men and 135,000 women, who were followed for 12 years. So here you can see the chance of developing heart disease, and none of these people had heart disease at baseline. The chance of developing heart disease was the highest in the people with the lowest SHBG. Now, there are at least two circumstances where a high SHBG is a predictor of disease, and one is osteoporosis. So this is a very recent paper with a very, very fine editorial by Sandeep Khosla, who's the expert in this kind of stuff. So here you can see that the higher your level of SHBG, the greater the risk of having any fracture, a hip fracture or a forearm fracture is higher when you have a high SHBG level. So here's where a high SHBG level is a biomarker. And an even more striking finding is this development of primary liver cancer. So these in that same study, UK Biobank, these 366 men developed liver cancer and 165 women in this multiple thousands over time. And look at the relationship between the SHBG and the risk of developing liver cancer, 8-fold here. And it's much more dramatic than in women. So if you're overweight and you lose weight, your SHBG rises. This is a study that I helped with a very long time ago. These were studied by a woman interested in obesity, Dr. Rena Wing, and they had a diet and exercise program for 12 weeks. And look how successful it was. Of course, when they stopped the program, they regained the weight. That was a follow-up paper. But with that weight loss, there's a marked increase in SHBG. This is a binding capacity, an old assay before we had the immunoassays. If you lose less weight, as in this study of a more tempered exercise and diet program, where they went from 86 kilos to 84 kilos, the insulin sensitivity improves. Right here, where they did a clamp, and the level of SHBG rises as well. If you lose a lot of weight with bariatric surgery, this is a change in BMI, so a BMI change of 16 kilograms, not the BMI itself, but the change in the BMI. And you can see that there's a large increase. Here's a change in the SHBG. It increased by 21 nanomoles per liter. So losing weight by gastric bypass surgery is very effective. And as you might expect, the use now of the GLP-1 receptor analog and the multi-receptor drugs are starting to provide additional information. This is a current paper. And you can see the tirzepatide for 2 months resulted in an 8% decrease in body weight and a 35% increase in SHBG, and even an increase in erectile function. We talked about erectile dysfunction and obesity and the metabolic syndrome with the fellows. And the point being that you don't really have to give testosterone, that you get more of an effect on erectile function with the GLP multi-receptor analog, and the SHBG level rise quite dramatically. So now we've talked about obesity, insulin resistance, and low SHBG production. And how might all of these things be related? How might they be related to diabetes, polycystic ovary disease, sleep apnea, CVD risk, MASLD? Obviously, obesity and insulin resistance are not a molecular mechanism. They're a disease entity, if you will. And among the things which have been proposed to play an important role are hyperinsulinemia, hepatic steatosis, and inflammatory cytokines. And is the low SHBG level simply a marker for these problems? Or does the low SHBG somehow predispose to hepatic steatosis? Or does it have an effect on these endpoints because it affects cell proliferation and metabolic pathways? So the amount of SHBG in the peripheral blood is intimately related to this transcription factor, a nuclear receptor factor called HNF4 alpha. And HNF4 alpha is expressed primarily in the liver, but it's found in the pancreas, kidney, and intestine, mainly in the liver. And if you're a mouse and have a deleted HNF4 alpha, it's embryonic lethal. And in experiments where HNF4 alpha are deleted subsequently through a conditional experiment, so they're not born with a deficiency, but it's acquired, the animals develop large livers that have lots of fat in them. And HNF4 alpha is thought to play a very important role in the metabolic syndrome and in a variety of other diseases. So HNF4 alpha was found to activate the SHBG promoter by Jeff Hammond and his group in around 2000. So here's the HNF alpha gene. Here it is, and the protein then binds to these sites in the promoter of the SHBG. They're antagonized a little bit by something called COOP-DF, and other important regulators or other known regulators include the pregnane X receptor, the estrogen receptor alpha. I showed you estrogens increase SHBG. The PPAR gamma agonist, and that CAR or CAR. I forgot exactly for the moment what CAR stands for. I'm sorry. So two of our fellows, Dr. Goganini and Dr. Karagar, helped collect liver specimens that were removed by Dr. Scoggins, who's a cancer cancer surgeon, surgical oncologist. And he was removing liver from patients who needed a partial hepatectomy as a treatment for their disease. And we were able to obtain the normal liver surrounding the tumor. And we were able to get some blood from the patients, and we were able to get their consents, thanks to Dr. Goganini and Dr. Carrigar out there being good about it. So here you can see the SHBG in the peripheral blood and the SHBG mRNA in the liver samples. And here are men and here are women, and you can see there's a very strong positive association. So the major determinant of how much SHBG you have in your blood is the level of expression in the liver. So here you can see two women who were treated with estrogens. At least one woman who was very thin, and we've talked about both of those as determinants of SHBG in the peripheral blood. And a fascinating one, this tamoxifen here, one woman was treated with tamoxifen, but had a very low level of SHBG mRNA. And tamoxifen is known to affect glycosylation. And it may be that this woman's SHBG protein was variably glycosylated, explain why it was such a deviant from the normal anticipated result. When we measured HNF4 alpha in the same samples, we found, again, a very, very strong positive correlation between the level of HNF4 alpha mRNA and SHBG mRNA. So how important the insulin level is in this is a little bit controversial, and you may read papers that disparage the connection between insulin, hyperinsulinemia, and low SHBG. I embrace it. I think they've made a mistake, and I'll show you why. So first, this is a level, it shows the level of insulin and HNF4 alpha in the DBDB mice, which are leptin receptor deficient, and they're very obese. So these animals are hyperinsulinemic and have HNF4 alpha deficiency. And here in the hep G2 cell line and in the hep G3B cell line, you can see that when you add more insulin, which is here, to the culture media, that you get lower levels of HNF4 alpha in both cell lines. So it's clear to me that insulin lowers the HNF4 alpha. This group could not confirm it. This Dr. Selva, who worked with Hammond and then moved to Spain on his own, they reported in the 2007 that insulin didn't suppress SHBG. And instead, they showed that SHBG was suppressed. This is the protein for SHBG by glucose and by fructose when added in concentrations of 10 millimolar to the culture media. And they showed that the same treatments affect the levels of HNF4 alpha mRNA and SHBG mRNA in this cell line. But as I told you before, hyperglycemia and type 1 diabetes doesn't result in a low SHBG. So I think that these are a phenomenon that relate to HepG2 cells and don't eliminate the effect of insulin as a regulator of HNF4 alpha and SHBG. But you will read that. There's more of an agreement about how the fatty acids and fat in the liver cause the production of a variety of cytokines. So here, from the same group, is the production of SHBG and the SHBG mRNA when TNF alpha is added to the cells. And it's quite convincing. So I believe that's true, but I also believe that insulin is also one of the important mediators. So this gets back to the idea of genetic regulation of SHBG. This Ding et al., writing in the New England Journal in 2009, pointed out that there are polymorphisms in the SHBG gene which are associated with decreases or increases in SHBG levels. I pointed that out before. And there are numbers are 6257 and 6259. And here you can see that 6259, which results in an increase in the level of SHBG, results in a decrease in the chance of getting diabetes. And 6257, which results in a decrease in SHBG, results in an increase in SHBG. So this is important because these polymorphisms are present lifelong. And the idea is that the lifelong effect of SHBG increases the risk for diabetes because of these associations. So the idea then is that the SHBG raising only either by altering steroid function or by some direct effects somehow causes the diabetes to be occur less often. Whereas the lower SHBG levels from the other polymorphism results then in lower altered SHBG function, perhaps, and perhaps the SHBG affects beta cells, perhaps it affects insulin resistance, and it increases the risk for diabetes. So this suggests then that SHBG may have some direct effects on tissues. And some years ago, a researcher in Columbia, New York City, Bill Rosner, said that adding SHBG to a variety of slices of different tissues and a variety of cell cultures, tissue cell cultures, could increase the production of cyclic AMP. But others have not been able to confirm that, and no one has been able to identify a receptor for cyclic AMP. More recently, a connection with a GPR receptor, G protein coupled receptor C6A, has been published. And this is the receptor for something called osteocalcin, which is produced by bone cells. And this receptor activates the phosphorylation of ERK, as shown here. So when you add the osteocalcin, you get a increase in phospho-ERK. And when you add SHBG, in addition to that, you get a decrease in the amount of phospho-ERK, whereas the SHBG added itself didn't do anything. So it seems like the SHBG can antagonize the actions of osteocalcin without any direct stimulatory effects. And now the final slide here talks about mouse models. You know how informative mouse models are in conducting endocrine research. And what this group did, this is again Simo, the guy who traded with Jeff Hammond. And what they did in this experiment is they made a mouse that overexpressed the SHBG gene. In general, mice and rats produce little or no SHBG in adulthood. And that is therefore a real limitation in studying SHBG using mouse genetic models. But you can overexpress it. And that's what they did here. So this is then the high-fat diet SHBG animals shown here. And this is their body weight as they grow older. And this is the high-fat diet wild type as they grow older. So having the SHBG gene results in a lower body mass, body weight in mice in this study. And here's another clever study where they took the SHBG transgenic mice and mated them with the leptin receptor DBDB mice. So here the DBDB mice, you can see, have much heavier livers. And you can see then that when the DBDB mice were crossed with the SHBG mice, the livers were smaller. Now the effect here is much more pronounced for males and females. And remember, the effect of SHBG on testosterone is much more pronounced than it is on estradiol. So this makes me a little suspicious that they might be looking at a steroid hormone effect and not a SHBG effect. For females, though, had a similar amount of decrease in visceral adipose tissue as did the males if they had the SHBG transgene. But these results were published in 2015, and this research seems to have come to a halt. There hasn't been anybody who's confirmed or expanded or extrapolated any of this. So whether this is an effective SHBG on tissues or not, and I remember how this effect might happen. We don't think it increases cyclic AMP. It didn't have any direct effect on the signaling through the osteocalcin receptor. No one really knows how SHBG might affect tissues directly. So SHBG is a hepatic glycoprotein that binds testosterone and other steroids with high affinity and regulates hormone access to target cells. Low SHBG levels are associated with obesity and increase the risk for developing metabolic syndrome, fatty liver disease, diabetes, and other metabolic disorders. Insulin and pro-inflammatory cytokines are presumed important mediators of the low SHBG in patients with obesity and insulin resistance, but other regulators are likely. Genetic studies suggest that SHBG polymorphisms may contribute to the development of insulin resistance and diabetes. The mechanism for these direct effects remains unclear. And finally, low plasma SHBG levels may become an attractive measure for the identification of metabolic disorders beginning early in life. Thanks for your attention. Okay.
Thank you.
Do you do the discussion?
Yeah.
Give me a chance to sit down.
Okay.
Yeah. I'll get up and read. I
Be
just if there are any
careful.
questions.
Dr. Victor, that arm is broken there.
Okay.
We should be careful. I have a question. It was a great overview. And my question was on the slide after Dr. Fosler's editorial. I understand the high SHBG and the low bone density because in a way it's the leanness and many times the older men, high SHBG could actually be totally low testosterone
Right.
level.
Maybe it's a direct effect.
Yeah, it's a direct effect too. So
Maybe.
the slide after that.
The liver cancer?
Yes, so if you think that low SHBG sometimes is a mast cell and hepatocellular cancer risk.
Low SHBG.
Yeah, but this case, you showed high SHBG and primary liver cancer.
Right.
What is the connection there?
I don't think they know. There's just an observation as to why it would cause primary liver cancer. I think the low levels are associated with problems with fatty liver disease and alcoholic steatohepatitis. But this deals with liver cancer.
Yeah, but mast cell.
No, I'm sure they go on to develop, but that must be a separate story.
Okay.
Any other questions? Are they out there?
I don't see anything here yet.
We have a question.
Hi, Dr. Leonard.
So there's one question here. There's, can you comment on the difference in SHBG in pediatric versus adult metabolic obesity diabetes syndromes?
Can you comment? Can you comment? I don't see it. Where is it?
It's here.
Can you comment on the difference in SHBG in pediatric versus adult metabolic obesity syndromes? Well, I think that, I don't know that there is a difference. I think that if you look at the reference group, that the pediatric patients have lower SHBG, who have the children who have the metabolic syndrome have lower SHBG, just like the adults. There are obviously very strong differences in the SHBG levels. I showed you those very high levels that seem to decline. And I'm fascinated with what might really be going on during childhood. Is this insulin resistance that is occurring over childhood? Does it occur in the pattern that I showed you for SHBG? I don't know. But I'm not convinced that there is a major difference in SHBG as it relates to the metabolic syndrome. But there are a lot of other differences. You don't have sex hormones in children, of course, and you have these very high levels, which be just after birth, for which I don't offer an explanation.
So in the fatty liver,
Hi, Dr. Menes.
yeah. You have questions, Swapna?
Yeah,
Yeah.
thank you, Swapna here. Thank you for the wonderful talk. I was wondering if there's any research on any direct correlation between low SHBG and cardiac events.
Cardiac event. Well, not necessarily lowering, just the fact that lower SHBG is associated with cardiac events. I mean, I think that, you know, there's going to be so much research now that comes about because of the GLP-1 receptor agonist class of drugs, that they're going to start looking at all of the endpoints way and beyond just body weight. And, you know, I found one study already that dealt with SHBG and testosterone, and I'm sure that that research is going to explode in the next few years, and your question will be answered, whether, you know, to what extent does SHBG fit in with the changes in body weight and insulin resistant that follow weight loss with that class of drugs. I mean, I think it's going to be a fascinating series of experiments.
Thank you.
Yeah.
Thank you very much.
Right? Right? Sure.
Higher cardiovascular.
Right. If I remember right, she tried to exclude PCOS, but even among those postmenopausal women, the hyperandrogenic women were more insulin resistant and had lower SHBG. I think that's right. That was a long time ago. Yeah, I think that's right. I don't remember that part.
So
but you
we
may
have
know.
this new, with the third hormone regulation, you have fatty liver with the third hormone beta receptor agonist,
Right,
you know, which reduces fatty liver and fibrosis,
right,
but also at the same time regulates SHBG.
right.
So is there data on that, are these
I
drugs
found-
even more effect on SHBG because there's two things happening? Because it will be reducing hepatic fat and
Right,
therefore improving insulin sensitivity.
right,
And it also has a direct effect on
right.
SHBG synthesis.
I don't know how you're going to separate those, but I did find a paper that did look at SHBG during treatment with this new drug for fatty liver disease, and the levels did rise. The other thing they fascinating do, they break down when they do those clinical trials, they break the subjects into a high SHBG group and a low SHBG group. And the low SHBG group, I think, doesn't do as well as the high SHBG group with the effect of the drug on the development or improvement in the fatty liver and inflammation. So not only are they using SHBG as looking at an outcome, but they're somehow using it to modulate and understand the results of the drug directly. But as far as answering your question, is it the effect of thyroid hormone beta, or is it the effect of the improvement in the liver fat? I don't know. Yes, Dan. Oh, I see what you mean.
I understand that it still is an independent
Right,
predictor, but, you know, I write mostly nowadays about biostatistics and prediction. And
right,
sometimes the prediction is extremely weak.
right,
You know, many of the things that you see in the literature with an effect size, say, a relative risk of 1.2, that's a very weak relation. So I'm just wondering how much effect, you know, I'd like to know more about the details, if you know it.
off the top of my head, I don't know to what extent they've controlled for BMI in the studies that have looked to show that insulin resistance, I think they're all tied up together. I think what you said is quite true. And it's separating all those factors which are interrelated is a real challenge, but I don't know the answer to that question. All right, let's see if we got all the questions. Want to go back and. Any other questions?
Let me see here. No, that's it.
No. Just accolades. Thank you. All right, well, thank you for your attention, both in the hinterland and here in 038. And it's a pleasure to be back and meeting some of you who I haven't met before. Have a nice evening.